So today the topic of our PTGCR is a case presentation of the physiotherapeutic management of chronic moderate right knee pain in 60-year-old female with osteoarthritis. And today's combined round is in the collaboration with the Department of Orthopedics of Mahatma, the Medical College and Hospital. And with us, we also have Dr. V.K. Kapoor, sir, Pro Vice Chancellor, MGUMST, who has always guided us towards this PTGCR, these combined rounds, and has always helped us in understanding how collaborative work can help in a holistic development and holistic treatment for our patients. As we are reaching further towards the 25th physiotherapy combined round, after each and every combined round, we are learning more and more new things about the medical management as well as the physiotherapeutic management in the various different areas, in the various different fields like orthopedic, cardiopulmonary, oncology, and so on. Today with us, we have Dr. Nimawat and Dr. Tapas Samanta as our speakers. I would like to request Dr. Nimawat, sir, to please come forward.
Good afternoon, respected Dr. V.K. Kapoor sir and all the faculty members. Myself, Dr. Nimawat, second year orthopedic resident. Today I am presenting osteoarthritis of knee under the guidance of Dr. Mahatma sir. So first, what is the osteoarthritis? The osteoarthritis is a non-inflammatory degenerative condition which is characterized by degeneration of the articular cartilage and formation of the new one, which is called osteophytes. It is one of the main joint of the lower limb, and for the routine daily activities of the person, it is a very important joint. There are two types of osteoarthritis: primary osteoarthritis and secondary osteoarthritis. The primary osteoarthritis is more common osteoarthritis than the secondary. It is more common seen in the elderly patient. The cause is unknown. It is mainly due to the wear and tear changes occurring in the old ages, mainly due to the weight bearing. The secondary osteoarthritis, it is due to the predisposing cause such as injury to the joint, previous infection, rheumatoid arthritis, infirmity, obesity, and the hyperthyroidism. Epidemiology. Knee osteoarthritis most common cause of disabilities in the adults. It decreases the work productivity and frequent sick days. It has highest medical expenses of all arthritis conditions. Due to the habit of sitting cross-legged and squatting, osteoarthritis is more prevalent in the India. The symptomatic knee osteoarthritis is seen in more than 11% of the population which is above 64 years of age. The pathology. Osteoarthritis is a degenerative condition primarily affecting the articular cartilage. After that, the bone, synovial membrane, capsule, and the ligament and the muscles will be involved. The first, articular cartilage. The articular cartilage is the lower end of the femur, which is called condyle of the femur. It is covered by the thick articular cartilage about 0.5 to 1 centimeter in the thickness. Similarly, in the upper end of the tibia, which is also called condyle of the tibia, is also covered by the 0.5 to 1 centimeter thickness of the articular cartilage. The articular cartilage is a smooth, shiny, and elastic structure which serves the function of a shock absorber in the knee joint. The cartilage is the first structure affected in the osteoarthritis of knee, which erosion occurs, which is often central and frequently in the weight-bearing areas of the knee. Here we can see in the right side, it is seen in the early osteoarthritic changes, which is the cartilage loss in the central. And in the left side, it is more advanced changes with extensive cartilage loss and exposed underlying bone. So, what are the risk factors of the osteoarthritis of knee? First of all, the age. The age is more than 45 years. It is most predominantly seen in the female, which is more common in the postmenopausal women. The third is the obesity. Previous knee injuries, lower extremity malalignment, habit of squatting and sitting in the cross-leg position, high impact activities, muscle weakness, and the osteoporosis. The patient comes with the pain, complaints of pain and swelling, joint stiffness, crepitus, varus deformity, synovial thickening and diffusion in the knee joint, and the reduced range of motion of the knee joint. How can we diagnose osteoarthritis of knee? So first of all, we advise patient X-ray, which is AP and lateral view of the knee in the standing position, and some tests which are CBC, ESR, and CRP for rule out any infectious pathology, and rheumatoid factor and anti-CCP for rule out any rheumatoid arthritis pathology. Here we can see the normal X-ray of the knee in AP view. Here we can see the normal joint space. In the second image, we can see the reduced joint space in the medial side of the knee. Pellegrin and Lawrence grading of the osteoarthritis of knee. Here we can see the 4 grading of the osteoarthritis. In the grade 1, there is a doubtful narrowing of the joint space. In the grade 2, there is a minimal decreasing in the joint space and definite osteophytes. In the grade 3, we can see the moderate multiple osteophytes and more narrowing of the joint space. And in the grade 4, there are sclerosing of the articular surface and the increasing narrowing in the joint space and definite deformity of the bone contour. In the grade 4, the patient will come with the varus deformity. So management. First is the lifestyle modification, second medical management, and third is the surgical management. In the lifestyle modification, we advise patient to do weight loss, the nutritional exercise program to improve cartilage nutrition, muscle strength, and prevent progression of the osteoarthritis and deformity. In which we can advise patient to physiotherapy like quadriceps training, range of motion exercises, low impact activities like swimming and biking, avoid high stress activity like jumping, running, and stair climbing. The ambulatory assist devices are cane in the walker and insoles and unloader knee braces in the. After that, second is the medical management. In the medical management, there is a chondroprotective agents which are glucosamine, chondroitin, collagen polypeptide, diazepam, and rosic powder, which help in the cartilage repair. After that, for the pain relief, there are acetaminophen and NSAIDs like diclofenac, aceclofenac, COX-2 inhibitor like celecoxib and interocoxib. After that, pain persists, then we can give opioids like tramadol and the intra-articular injections like glucocorticoids and hyaluronate. And after that, the anti-osteoporotic treatment like we can give bisphosphonate injections and antioxidants like vitamin A, C, E. So in the algorithm, firstly we can give lifestyle modification acetaminophen. After that, we can give NSAIDs and celecoxib. After that, steroid injections and opioids, and then hyaluronate injection, and then surgical treatment. If the patient is in the early osteoarthritic changes, we can refer patient to the physiotherapy department for further management. Thank you.
Thank you so much, sir, for highlighting the aspects of osteoarthritis. Now I would like to request Dr. Tapas sir to come forward and share some physiotherapy management of the patient with the right knee osteoarthritic pain.
Yes, thank you, Didi. A very good morning to respected Dr. D.K. Kapur sir. Sir, you are my inspiration in my research choice, sir. Directly respected my principal, Dr. Monsur, sir, my HOD, Dr. Selim, Dr. Nagri sir, all professors, Dr. Orban, Kumar sir, and all faculty members, and all my dear students present here. It's my privilege to be here in front of you today. I am Dr. Tapas Samanta. I am presenting my 22nd physiotherapy combined round this year in the help of my guide, Professor Dr. Lokesh Sharma. So my topic is a case presentation of physiotherapy management of chronic moderate right knee pain in 60-year-old female with osteoarthritis. So what is the demographic and the clinical presentation I got? My patient, she is a 60-year-old female, she is a teacher and and see complaints about the chronic moderate pain in the right knee for the past 3 years. She diagnosed as right knee osteoarthritis, OA, likely grade 2 or grade 3 in the moderate range. And her duration was, it was chronic 3 years history of progressive pain. Her symptom was moderate intensity of pain, especially with weight bearing, walking, standing, and squatting. She complains with, she had a morning stiffness of a last of 30 minutes, resolving with activity. Her physical findings, I observed, it was a potential medial tenderness, reduced range of motion, crepitus, grinding sensation, and possible varus deformity. It was mild. Then, what was the impact on her lifestyle? What I observed in our orthopedic OPD of the Mahatma Gandhi Medical College and Hospital OPD, we are much likely reduced mobility and limited ability to exercises. Then coming to the clinical assessment, it consists of subjective and the objective also. So what she present her illness, so what we observe, it is a gradual onset of the right knee pain. It is aggravated by the activities such as walking, climbing stairs, squatting, and the prolonged standing, and pain reduces with rest. Then past medical history, what I got, no history of the surgery, no neurological disorders, no history of any inflammatory arthritis, no history of the trauma or fall. So what is pain assessment I got? It was the dull and the aching type of pain. Then it was the moderate kind of pain. And the outcome is a 101 NPR score, what I got at rest, C mark 54 point out of 100. And during activity, C mark 72 out of 100. Then coming to her physical status, what I got by my assessment. So what I observed, it was a mild swelling over the right knee joint, then varus alignment noted, then antalgic gait pattern. Then what I palpate, the arch tendon is along the medial joint line and local bone pressure. Then the range of motion, in the context of knee flexion, it was reduced and painful. The knee extension, it was the terminal restriction. And muscle strain in the quadriceps and hamstring, both are the 3 plus to 4 out of 5. And then I did this special test. It was a crepitus present during knee movement, and the diagnostic imaging, what I got from the orthopedic OPD, it was a conventional radiograph X-ray of the knee is the gold standard. It reveals that the joint space narrowing and the subchondral sclerosis and osteoarthritic formation. Then what is the physiotherapy goal I set for my patient? First is the short-term goal and second point is the long-term goal. So I had a short-term goal for her. It was the reduced pain and inflammation, improved knee range of motion, then decreased joint stiffness and improved muscle strength. Then second point, it is very vital. It is a long-term goal. It was also the improved muscle strength, enhance the functional mobility and improve quality of life and independence. Then coming to the management, it is very vital. So the management focuses on relieving symptoms, enhancing functions and slowing the progression. So first is the first line, but non-pharmacological. First is the education and the self-management. Here, understanding that pain does not always equal damage, and that activates. That activity is good. That point is very vital for the patient. Then coming to the exercise therapy. Supervised physiotherapy treatment combined with home exercise is most effective. Focus on the strengthening the quadriceps, hamstring and hip abductor muscles to reduce loading on the knees. Then coming to my treatment protocol. So I had the first week exercise protocol and next is the second to third week exercise protocol. So first week exercise protocol, I kept hot pack for 30 minutes, will be given before the exercises, then isometric quadriceps exercises, then isometric hamstring exercises, and the do's and don'ts: do not squat and avoid floor sitting habits. Then my brief layout about my protocol. So first week exercise protocol, it is a hot pack. It is the application of heat to the body resulting in increased tissue temperature. Techniques for the application of hot packs to the body surface will be safe and efficient manner. Hot pack is used in rehabilitation to reduce pain and stiffness and to increase mobility. It helps to relax muscles and increase circulation to the affected area, thus reducing the pain and stiffness. Although there is some concern that this may in turn worsen inflammation and edema, hot pack can be self-applied easily by the patient at home, such as the use of heat packs, and may also be combined with other rehabilitation interventions. And there have been reports in recent years that different forms of thermotherapy have been widely used in the clinical practice. It has been used to treat knee osteoarthritis and has achieved significant result. Now coming to the isometric quadriceps exercises. What is that? Isometric quadriceps exercises involve tightening the thigh muscles without moving the knee joint. These are highly effective for maintaining muscle mass before or after surgery, reducing knee pain from conditions like osteoarthritis and improving stability. Now coming to the classical methods, sit or lie down on bed with your legs straight, tighten your thigh muscles by pressing the back of your knee firmly into the floor or on a tile roll. Hold for 10 seconds. Do not hold your breath. It is common to stop breathing during isometric holds, which can spike blood pressure. Focus on even, steady breaths. Vary the angles. Isometric strain is specific to the angle trend. For maximum benefits, perform holds at different degree of deflections. As example, 90 degree, 45 degree, and the full extension. Now coming to the progression, start with 10 seconds holds and twice in a day for 10 repetitions, and gradually increase the repetitions as the endurance improves. Then coming to the next point, isometric hamstring exercises. Isometric hamstring exercises involve holding a muscle contraction without moving the surrounding joints. They are highly effective for rehabilitation, tendon loading, and the injury prevention. Then coming to the classical methods, lie on your back with your feet rest on the bed, keep a towel roll beneath the ankle joints. Now patient will generate sustained pressure on the towel roll and holds for 10 seconds. Repeat same procedure for 10 repetitions and twice a day, gradually increase the repetitions as the endurance improves. Then coming to progression. Start with bilateral or two-leg exercise and progress to single leg holds to increase intensity and address the imbalances. This is my exercise I am teaching in our orthopedic OPD of Mahatma Medical College Hospital. First slide, sir. Sir, you can observe I am teaching my patient how to do the isometric quadriceps exercises, and she is following well, and we got a result well. And sir, this photograph, it is isometric hamstring exercise, second photograph. She is following my advice how to do hamstring and where, and she does this. Then coming to the treatment protocol, second to third week exercise protocol. Again, hot pack for 30 minutes will be given before exercises. Here I include straight leg raising exercises, SLR. Straight leg raising, SLR are the versatile movements used both as a rehabilitation exercises to strengthen the lower body and as a diagnostic test to identify the nerve issues. Primarily, it helps the quadriceps, that is front of the thigh and the flexors. Coming to the classical methods, lie flat on your back on a firm surface, bend one knee and keep that foot flat on the floor for back support. Tighten the thigh muscles, that is quadriceps of your straight leg. Slowly lift the straight leg about 6 to 10 inches off the floor. Hold for 10 seconds. Then lower slowly with control. Repeat it with weight as endurance improves. But avoid if patient is having the acute lower back pain or the acute sciatica flare-ups, as lifting both legs or an unsupported straight leg can increase the spinal pressure. Then I'm coming to the progressive resistor exercises PRE. That is, I am using here the long techniques of the weight up. Progressive resistor exercise PRE includes straight leg raiser SLR and the dynamic quadriceps exercises. The long exercise technique, it is a method of a progressive resistance exercise used in the physical therapy developed by Dr. Thomas L. DeLong in the 1940s during the World War II. This technique, originally called progressive resistance exercise or PRE, is a strength training protocol used for muscle rehabilitation. Then coming to my principle, it is a method of isochronic exercises with weights that involves performing sets of repetitions with increasing resistance. Then coming to the protocol. The program is based on determining a patient's 10 repetitions maximum, that is 10 RM weight, that is the maximum weight they can lift at times. The training involves 3 sets of the 10 repetitions with rest in between using progressively heavier weight. Set 1, 10 repetitions at 50% of the 10 RM. Set 2, 10 repetitions at 75% of 10 RM. Set 3, 10 repetitions at 100% of the RM. Then coming to my next exercise, dynamic quadriceps exercises. Dynamic quadriceps exercises involve active movement through a joint's full range of motion to build strength, power, and the stability. Unlike static exercises that involves holding a position, these dynamic movements are excellent for warm-ups or the functional training. Then coming to the classical methods, sit up on a high chair and ask the patient to straighten the one leg from the knee joint and hold for 10 seconds. Then repeat it with weights half or 1 kg. Gradually increase the repetitions as the endurance improves. 10 repetitions and twice a day. It will help to strengthen the quadriceps muscles and stabilize the joint. This is the photograph of my 2 exercises. I took from the orthopedic OPD of the MGUMST hospital, MGUMST. So first, these photographs are I'm instructing my patient for SLR, straight leg raising, how to do, how to hold, when to keep a weight, when to start, and she's following, and she's doing it fantastic. Then there's second photograph, it is a dynamic quadriceps exercise, this photograph. She's also following my instruction, and she does, and we got a good result. Then sir, outcome measure, what I do? Sir, I have 2 outcome measure. One is for pain intensity, second is for the mobility. Sir, for pain intensity, 100 NPRS, numerical pain rating scale. It is a standard clinical tool used to measure pain intensity, while the scale itself is usually 0 to 100. The 101 notation often signifies a 101 point scale that is ranging from 0 to 100, used for more granular assessment. Then coming to the purpose. It quantifies pain intensity based on patient self-reporting 0 to 100, 101 point scale, providing high resolutions, allowing patients to indicate small changes in the pain levels. Then coming to sir, my mobility outcome measure, that is the time up and board start. It is a simple clinical tool used to assess a person's mobility, balance and fall risk. It measures the time in seconds it takes for an individual to stand up from a chair, walk 3 meters, about 10 feet, turn around, walk back and sit down again. Then coming to the scoring interpretations. A faster time indicates better functional mobility, while slower times suggest impairments. Less than 10 seconds, it is a normal mobility. The individual is generally independent. Then 10 to 20 seconds, it is a good mobility, usually independent and can go outside alone. Then 20 to 30 seconds, it is a mobility problem. The individuals may need a walking aid or assistance when outdoors. Then more than 30 seconds, it is a significant mobility impairment, indicates a high dependency and likely need for consistent assistance. So sir, this is my outcome. I observed on my patient. It is really fantastic improvement in my patient. With consistent management, patient is improved than before. First, I observed, I got, sir, it is a reduced 101 MPRS pen score, it is improved, improved means it is lesser, improved ability to perform daily tasks, walking, austere climbing, delayed need for the knee replacement surgery, it is, I hope so, we can proceed with that, then increased muscle strength and better functional performance in daily activities. This is the outcome I got on my patients. Now coming to the prognosis, with consistent adherence to a multidisciplinary conservative management plan, the patient is improved in the context of functional capacity, reduced pain and improved quality of life, avoiding or delaying the need for the surgical interventions. Then sir, finally I am coming to my conclusion. Physiotherapy played a significant role in managing chronic knee osteoarthritis by reducing pain, improving joint mobility and enhancing functional independence in the patient. Then sir, please observe, this is my video I got from the orthopedic OPD, what is the improvement and feedback of my patient. Please listen.